A question, are there any physicians in the room? Nurse practitioners? Physician's assistants? Oh, good, I can say what I want. No. Okay, well, we're going to talk about three things. Where have all the doctors gone? We'll talk about the shortage of primary care physicians. Do you speak doctor? Dealing with jargon and things like that that you hear in your doctor's office. And then some of the dark side of health insurance. And all of these things impact all of us. Okay, this is the problem around physicians. Currently, there's a primary care physician shortage of 21,400, and it's predicted by 2033 to be over 55,000. And probably these numbers are on the low side. It probably will be worse than that. This has been in the news. I'm sure you've seen some of the headlines around this. Wait times have surged in recent years. Second one is very interesting. I just read about this last week. Almost 1,000 physicians have applied for jobs in Canada, mainly because of politics and how difficult it is to practice medicine here, and the Canadians are snapping them up. And about half of them are primary care physicians. And they tend to be going to the more rural areas of Canada, like Alberta and Saskatchewan and places like that. Mass General, we're losing doctors every day. And you're much more likely now to see a nurse practitioner or a physician's assistant when you go to your primary care office. And ranked against other states, our doctor to patient ratio is 40% worse than most of the country. So there's a real situation here. A dire diagnosis is a new report that was put out by the Mass Health Policy Commission, which is a state agency. And if you Google it, you can look at the whole report online. And a lot of the information I'm providing today comes from that report. So, our state has the highest per capita number of doctors in the country. More doctors per person than anywhere. The issue is they're all specialists, most of them tied to the academic medical centers in Boston and Worcester. When it comes to primary care, we're the 5th lowest per capita in the country. So we have more doctors than anybody else, but fewer primary care physicians. We have the 2nd longest wait times for a new patient appointment compared to the other large metropolitan areas in the country. The only place that's worse than us is Portland, Oregon. 41% of state residents report difficulty accessing care. And interestingly, almost half of ER visits are unnecessary and could have been taken care of in a primary care office. The issue is supply and demand. The demand side is rather simple. The population is growing, the population is aging, and the people who are aging are sicker than the current older population. So all of this says we need a lot more doctors. Between now and 2030, the population as a whole will grow by about 7 million. But interestingly, the older population will be a higher percent of the current. So currently, 17% are 65 and older. By 2030, it'll be 21%. And you can see a lot more older adults. And pervasive health issues, going to point mostly to diabetes. Currently, 17 million older adults have diabetes. In 2030, that will increase to 21 million. That alone, if you know about all the complications of diabetes and the care that's needed, is really quite a staggering figure. And the graph is just showing how we're aging, and by the middle of the century, older adults will be 23% of the population, while children will be about 20% of the population. So big changes. The supply side, the doctor side, is a lot more complicated. And all of these things are factors in what's happening to all of our doctors, but especially primary care. They're aging, they're burnt out, they're maldistributed around the country and by practice, financial issues, and corporate takeovers and new models of practice, which I'll talk about all of these. So aging, this is Massachusetts, and you can see that a third of our primary care physicians are aging and are tending, because they're getting near retirement age, are getting out earlier than usual. In previous times, a lot of primary care physicians would work into their 70s and later, but they're not doing that anymore. Why is this doctor smiling? He's looking out the window at a golf course. He was and saying, soon, soon. Okay, physician burnout. And I'll read that first sentence. Beyond the low pay, primary care can be an exhausting job, requiring myriad billing and administrative tasks, increased documentation requirements, and overbooked schedules that undermine the core principle of primary care, that's caring for patients. As we go through this, I bet you that some of you in the room have said expletives about your physicians because you can't get appointments. I've heard 3 or 4 friends really complaining, and the doctor won't see me, and the doctor is, I don't know what he's doing. But after this, I want you to love your doctor more and really appreciate why you're not able to see a primary care. So this survey, the first one of 21,000 doctors in the state, was conducted by the Massachusetts Medical Society. And they found that 55% report they're burning out. And 27% said they intend to leave medicine by 2026. These numbers are probably higher than reality because at the time that the survey was done, you were asking a doctor how he or she was feeling. So it's probably overreported, but that's still concerning. In another survey, 24% have already reduced clinical care hours. So they're working 4 days instead of 5. And 24% said they're definitely or likely to reduce hours in the coming year. So why are they burned out? Too many bureaucratic tasks. I find it hard to believe, but the average primary care physician spends as much or twice the time doing administrative and bureaucratic work rather than seeing patients. So I know that my own primary care sees patients all day, goes home, and she's up to 10, 11 o'clock at night doing bureaucratic stuff. Too many hours at work. And I highlighted a few of these things. Lack of respect from administration and colleagues. I'll get a little bit more into this later because the majority of physicians now are employees of organizations. Organizations who own medical care make money by physicians referring for procedures. So the more procedures, the more hospitalizations, the more outpatient surgery, the more money those organizations make. And guess what? Primary care physicians don't do procedures. So they're at the bottom of the totem pole in terms of value to large organizations. I was in practice for 6 years. I didn't do a single procedure in those 6 years. I did refer some kids for procedures. So right now, pediatricians are the lowest paid in these systems. And they're actually feeling disrespected by colleagues in the practice who are more valued. Insufficient compensation, I'll talk about that a little bit later and show you some slides. Loss of control and autonomy. Doctors, including me, are control freaks. And when they begin to lose their autonomy because they're employees, it's very frustrating. Electronic health records. As you know, you'll sit in your doctor's office, and half the time they're looking at a screen typing. These records have been around since about 2000, but they became important and prominent with the implementation of Obamacare in 2010. And the initial intent was a good one. It was to reduce medical errors. So if everything is in an electronic health record, that can be shared with other doctors. You don't have to worry about, reading doctors' handwriting. And it was really a very good idea. And those electronic records included things like electronic prescribing, so you don't have to carry a, unreadable prescription to the pharmacy. So the original intent was good. But what's happened is that as corporate America has taken over practices, that health record now becomes important to them to be able to get the money they need to bill and things like that. So they push the doctors. There's a lot more clicks than was originally intended. And a lot of those clicks have to do with coding and things like that that have nothing to do with patient care. Physicians hate this. It also interferes with their interaction with the patient, but it's required. And dealing with insurance companies, you probably have all read about some of the things going on at United Healthcare and this whole business of prior authorization. It's a real problem for doctors because they order a test and then the test is denied. The doctor has to call back. Marion was recently given a prescription which was denied, and we found out that her doctor was on the phone with the PBM for about an hour, just for that one prescription. So it drives them nuts. And also probably one of the worst things is it makes the physicians feel bad because they can't give the kind of care they want to give or spend the kind of time they want to spend. And they feel like they're shortchanging their patients. They're too rushed, they don't have time to listen, and they don't feel like they're always providing the best care. Now, in terms of maldistribution, this is an interesting slide. The pipeline for new physicians are you go to medical school and then you do a residency in some kind of specialty. And the three primary care specialties are family medicine, internal medicine, and pediatrics. When you graduate from medical school, you choose what you want to do and where you want to go. And there's an organization called the Matching Program, and they match you to a residency program somewhere in the country. The blue lines and the percentages and numbers are residency programs that are not filled. So that means for family medicine, there were over 1,200 slots to train family doctors that were not filled. So anybody who wanted to be family doc could find a slot, but enough didn't, so those are empty. If you look down at the bottom, neurological surgery, you have to beg, plead, control, anything to get a slot. They're not available. So they get filled up very, very quickly, and there are always physicians, medical student graduates, waiting for a neurosurgery slot. They'll actually take a year off if they can get a slot next year. It's a big difference in who wants to go where. Now, a lot of that is financial. The average medical student leaves medical school owing way over $200,000. That's a lot of money. So when you're faced with making a decision about what kind of doctor you want to be, you're going to pick a specialty where you can make a lot of money. And like I said before, lowest paid are pediatricians. So nobody wants to go into pediatrics now. Maybe pediatric surgery or pediatric cardiology, because you do things. So you have all of this debt. This is where I graduated from. I graduated in 1966. The 4 years cost me $10,000. $2,500 a year for everything: tuition, room, board, books, lab fees. And currently, that value would be about $100,000, which is not terrible. That's what it cost, the same school, that's what it costs today for 4 years, $368,000. And about 79 to 80% of students cannot afford that, so they get loans. My debt when I left, I owed $2,250, which in its current value is $22,000, which again is not a big burden. I borrowed $500 a year. 1 year it was $750 to pay for room and board. Marion and I were able to pay that off in 2 or 3 years. So I didn't have to make a choice that was based on finances. So the way we pay doctors, the more procedures you do, the more money you make. And what doctors get paid is keyed off of Medicare. So Medicare is the standard fee schedules, and a lot of insurance companies use that. They'll pay more, but they use those kinds of ratios. You can see the 3 highest paid and what the average salary was last year. And you can see the average salary for internal medicine and family medicine. Now, I put up as an example 3 fees that doctors get. Your primary care, these are Medicare numbers, and this is 10 years ago, would get $87 for a 30-minute visit, your annual physical. The doctor who did colonoscopy, which takes 24 minutes, would get $320, and the cataract surgeon would get $423. Fast forward, that outpatient visit now is $92, so it's gone up $5 in 10 years. The screening colonoscopy has gone up to almost $600, and the cataract extraction has also about doubled. So you can see, even as time goes on, the ratios for procedures go way up, whereas for primary care, it went up just a little bit. Corporate takeovers. 78% of all physicians in the country are employed. When I was in practice, it was about 5 to 10%. And you were sort of looked down upon if you went to work for a company. The model was solo practice or small practices, or you could work in research or teaching at a medical center. But that has totally flipped now. 55% work for health systems and hospitals, such as Cape Cod Healthcare, the community health centers around the country. Cape Cod Healthcare employs about 480 physicians. Of those, about 140 are primary care, so employees of the hospital. The other 23% work for-profit corporations. Private equity, which to me is the scariest one. A hedge fund will buy a practice, and what they're all about is over 3 or 4 years to make it more profitable and then sell it. So the thing here is just to make a lot of money. And then other corporate entities such as insurance companies and pharmacy chains also own physician practices and employ physicians. Fallout of this, we talked about loss of autonomy. They're profit-driven rather than patient-driven, increased admin burden on doctors, and there's an impact on the continuity of care. Because if a corporation owns a big practice, they don't care who sees the patient, as long as somebody sees the patient and they can collect. So if there's 4 or 5 primary cares, you call for an appointment, you may not always see the same doctor. And that really interferes with continuity of care. And then, of course, it brings with it a whole bunch of ethical concerns. So what are doctors doing? They're leaving medicine, early retirement, moving to non-clinical work. And there's a large number of physicians who are leaving clinical care or cutting down on clinical care, working for consulting firms and things like that, where they can actually make a huge amount of money. And they're forming unions. You probably have seen up in Boston, doctors, primary care doctors at Mass General have formed a union. And so that they can be in a negotiating position around not only salaries, but how they're treated and how much time they can spend with patients. That union was just formed, so it'll be interesting to see over time how it works out. And the last thing on that list is direct primary care models, which you probably know better as concierge medicine. And that is a growing phenomenon. So, if you're in one of those practices, you pay the concierge doctor out of your pocket anywhere from $2,000 to $10,000 a year. Mass General, for example, has a concierge practice in a fancy part of the hospital. You know, and you pay $10,000 a year to be part of that practice, and people actually come from all over the world to do that. What these practices do, you have much greater access. You can get an appointment the same day or the next day, only see the same doctor. The visits are much longer, and you have 24/7 access to talking to the doctor on the phone or emailing. The doctors love it because they see many less patients. A typical primary care practice has a panel of patients between 2,500 and 3,500 patients. Concierge practice around 300. So the concierge doctor will see 8 patients a day. Our primary care doctor sees 20 or more a day. So you can see that makes for a lot of time. And there's a big focus on prevention and wellness and chronic disease management. This has consequences for the healthcare system. It's great if you could afford it. Okay. One of the big companies in the country is called MDVIP. And there are a number of these companies springing up that help to place concierge practices in various states. So this is a brand new one that's here in Falmouth. If you're familiar with that new complex on Dillingham, next to the apartments, there's an upscale spa and some apartments and offices and a concierge practice that's brand new. And there are 2 of these practices, 5 on the Cape. There are 2 in Falmouth, which I wasn't aware of. 4 out of the 5, the practice is closed because they're completely filled. So these are very popular. They charge between $2,300 and $3,000 a year. Dr. Amari on the top, because she's new, is taking new patients, and she charges $3,000. The pros for a patient is greater access and continuity, there's no doubt about that. The cons are cost, and you still need to have health insurance. So you still have to pay for Medicare, still have to have a supplemental plan. For the physician, it's great. They have time, they have much better relationship with their patients, no corporate bureaucracy, much higher income, and there is no downside for them at all. Now, besides the $3,000 a year fee, these doctors also bill your insurance. So you'll say, well, how could they do that? Well, Medicare will pay that $92 for a half-hour physical, and the doctor can charge for that. But she is spending a half an hour more on each side. So you come to see her, you get your physical, you get what Medicare expects, but you get another full hour to talk about your health, to talk about your issues. She can do a lot more than my doctor can do in terms of time. So she's collecting the Medicare fees and the $3,000. So this company, this is one of a whole bunch. This company is in 45 states. They have 1,300 physicians who see about 400,000 patients, and they average 300 patients per physician. If these 1,300 primary care doctors were in a traditional practice, this is the number of patients they would see. 2,600,000 versus 400. So that's 2 million of us not receiving care from a primary care doctor because we're not paying for the concierge. And these are growing very, very rapidly. All the health systems in Boston have them. I had some friends for dinner last night, and they asked me if Cape Cod Healthcare had one. They think they did. I'm not aware of it, but I wouldn't be surprised. Okay, so who's going to see all of these patients who are not seeing PCPs? And the answer is what they're now calling advanced practice providers, which simply are nurse practitioners and PAs. They're growing in numbers rapidly. And I read this, those bullets up there in an article yesterday from a physicians leadership media group, calling that this is the end of the physician era and the beginning of the era of advanced practitioners. Physicians are in short supply and they're costly. If you look at the breakdown, PCP averages about $240,000. PAs and nurse practitioners make about half that. So you can hire 2 of them for every primary care physician. And the question is whether they're the answer to the workforce and budget issues. Massachusetts, because of the extreme lack of primary care, 2 or 3 years ago, gave nurse practitioners the right to get licensed and have independent practices the same as a primary care physician. So they can hang out a shingle and practice medicine. They can write prescriptions for narcotics, everything. For the most part, they're not doing that. They're being employed, by the same organizations that employ the primary care doctors. Now, here in the state, this is what NPs and PAs, for the most part, are doing. If you look at the bottom, the majority of nurse practitioners are going into primary care, working in primary care offices, where the PAs tend more to go into surgical subspecialties. And the reason for that partially is training. Nurse practitioners are trained as nurses first and then get more training in medical kinds of things. So nurses are much more holistic than most physicians. They like to spend time with patients. They're more empathetic for the most part than a lot of physicians. And when you add that to medical stuff, like being able to do physical exam and diagnosis, that's why they're allowed to practice independently. PAs are more trained like an assistant to a physician. They learn about procedures, doing a physical, so they're more like mini doctors. Don't quote me on that. But they too are doing a lot of care in primary care offices. But you'll find them in a lot of surgical subspecialty. I'll point to Marion again, has some joint issues, has needed shots into her joints, and they've been done by the PA in her surgeon's office, and he's terrific. So they're well trained, but a lot of people are very concerned. I'm going to see my doctor. I saw my doctor once for 10 minutes, and for the past 2 years, I've been seeing a nurse practitioner. Question is that good or is that bad, or neither? It really depends on how well they're trained, what their training is, what they are as humans, and you can say the same thing about physicians. And interestingly, when I see my primary care, who's absolutely wonderful, she'll spend 15 minutes with me. And if I come in with something other than being followed for my diabetes or something minor, I have an ache and pain in the knee, she doesn't take care of my knee. She sends me to see an orthopedic surgeon or to get an x-ray first. Nurse practitioner does the exact same thing. So there are, some big overlaps, but some differences. Physicians are trained to be diagnosticians, to treat, not necessarily treat, but to do what's called a differential diagnosis, and that's the core of medical training. Okay, so you've now gotten, you need to get your health care, and what should you do? And I forgot where I got this list, but I was sort of amused by it, but it really is correct. The number one thing that everybody said, this was doctors and nurses and administrators, is become friends with the nurse or the scheduler for that doctor's office. Schedule your next appointment while you're in the office and try to get an appointment first thing in the morning where you probably won't have to wait for 3 hours. Ask your insurance company for physicians who are seeing patients. Medicare, interestingly, is very good about that. You can go on Medicare, you can ask that question, you put in your zip code, and they'll give you a list of physicians who are taking Medicare and who have open practices. Check with Cape Cod Healthcare. I did that this morning. There's a thing called Physicians Accepting New Patients. Of the 145 primary care, as of today, 8 are taking new patients. The rest are not. 8. Don't be shy if you're not feeling well, you can't get an appointment and you're worried. Go to urgent care or go to the ER. You're having some tightness in your chest, don't wait. Use an on-demand telehealth company. Has anyone heard of Firefly Health? It's very interesting. A whole bunch of new companies have sprung up where you can get full medical care online. Firefly is one of the best of them. So you go online, type in Firefly Health, their thing will pop up, you get their app, it is completely free. And when you register, you put in your insurance information, you select a primary care doctor, a nurse practitioner, and a clinical coordinator who's going to help you through the system. Everything is done virtually. You do a complete history with the primary care on their version of Zoom. And then if you need to have somebody physically touch you, or you need an x-ray or something like that, they arrange for that. And it works. This friend who was over for dinner last night grew up here, had a primary care physician for 35 years who retired. For 2 years, he's been looking for a doctor. He found one, saw the doctor for 10 minutes, couldn't get another appointment for 6 months, couldn't get his high blood pressure medications refilled without seeing the doctor, but the doctor couldn't see him for 6 months. So he heard about Firefly from a friend. He is now a very happy, satisfied Firefly patient. He sits in his office. He had a physical last week in his office at work. Now, one thing to understand is that when you see a physician for a physical, the first thing you get is a history, an in-depth history. That history is the single most important thing. 80 to 85% of what your doctor knows about your health comes from the history, not the physical. It is unusual for your first appointment for a doctor to do a physical and find something that you didn't know about. It does happen, but it's not common. What they'll find on the physical is because you told them about it in the history. So most of what can happen face-to-face online. So they're becoming very popular. I think Firefly has 150,000 patients around the country. And I looked at their site after dinner last night, and all of their physicians and providers were all very well trained, all board certified. They took essentially all insurance that a regular primary care would take, and there's no fee for any of this. So they operate just like a primary care office. Locally, Firefly, if you need someone to look in your ears or something like that, was working with CVS in their mini clinic. They have a relationship with CVS. I think those mini clinics are closing, but they arrange with other providers to do that part of the visit. And then monitor your health at home. There's all kinds of devices. I'm wearing my watch, which woke me up in the middle of the night last night to tell me my pulse was too low. Interestingly, it dropped to 39. I don't know why. So there are a lot of resources, and there are online resources. Be a squeaky wheel. Call early in the day, be clear, it's urgent, follow up if you don't hear back, advocate for yourself, but be nice. Don't call up the office and start cursing, but keep pushing. Call every day until you get what you want. And if not, you may have to go on Firefly. So let me stop there for a minute because we're moving on to a different subject. Other questions about? Yeah, Diane. Correct, because your insurance probably won't pay for both, but that's a good question. I think you can. I think you can join and use somebody else, use a different primary care than one of theirs, but you can have all the other information and stuff and have a care coordinator. Amy?
My understanding is that physician's assistants don't have as much training as a nurse practitioner.
Yeah, I'm sorry, I left that out. Actually, they do have as much training. It's different. They cannot practice independently. A PA has to work under the supervision of a physician.
However, they get a PA, they get a BS, whatever it is.
Right.
Just a bachelor's degree. I know that nurse practitioners usually get a bachelor's degree in nursing and then they get a master's degree.
Correct.
So to me, that sounds like they get,
Correct.
more education.
What the PAs get that doesn't have a name are this 1 or 2 years of clinical rotation, at the end of which they have to become certified by a national organization. So if you look at the totality of their training, it's different, but it's,
I'm snapping pictures, and I just want to get permission to do that.
oh, sure.
Is that?
Oh, sure. If you want, I'll send you the slides. It just,
It seems to me, traditionally in Massachusetts, we take pride in our not-for-profit healthcare systems, small, medium, or large.
they're gone. Well, some aren't, but go. No. No.
So what is the consequence of ongoing tax exemption? Let's put it that way. Do you see that continuing? Obviously, there are big
Right.
systems, and of course, more comes in, no doubt.
Right.
Do you see any difference in the values instituted in not-for-profit, we'll call them, versus the for-profit companies that are prevalent all around?
Yeah, they're prevalent here too. I mean, 80% of doctors in this state are employed. If you look at Mass General, the hospital is non-for-profit, although Cape Cod Healthcare is not-for-profit. Their CEO makes $3 million a year, or $2.5 million. Correct. The doctors are it's complicated, and I don't want to mis-explain it. The physicians are part of Partners, which has a contract with Mass General. There are doctors who get a Mass General paycheck. They're, for the most part, in research and teaching and do see patients as part of that constellation. That's different from a lot of the Partners physicians. I'll give you an example in the state. There was a very large, very good nonprofit group called Atrius. Many of you may have heard of it. Had seen about 500,000 to 600,000 patients in the state. A year and a half ago, they were quietly bought by United Healthcare. It hasn't changed much, but physicians are beginning to see the change. It's no longer a not-for-profit organization.
So when Medicare pays my doctor, my
Yep.
primary $92, is that all for the physician, or does it go into a big bank under Cape Cod Health, and she gets a certain check?
If she is an employee and gets her paycheck from the hospital, then that goes into whatever. So she's putting in the electronic health record, the times and the diagnosis, and that payment will go to whoever Medicare has the contract with. So my doctor is not part of Cape Cod Healthcare. So she gets the $92. She works with off-Cape hospitals, but she's freestanding and independent. Another doctor across the street is an employee, and that money goes to Cape Cod Healthcare, who pay her a salary.
So should we ask our doctor if they are an employee of Cape Cod Health?
You could easily look it up online. So if you have your doctor's name, just go on Cape Cod Healthcare, and you can see if they're employed or not. Why would it make a difference if you're getting the care?
It doesn't.
Okay, just curious.
All of a sudden, Cape
Yep.
Cod Health owns so much property in this town that, it's astonishing.
Including most of the medical practices. Any other questions about? Yeah.
First of all, as you know, I'm from New York City, so I had what is old-fashioned primary care physician
Yep.
here. She spent a lot of time, she knew all about me. So it was an eye-opener when I had difficulty finding a primary care. And secondly, I thought he had autism because he never looked at me. He looked at his computer
Yep.
all the time.
Yep.
I still think he had a little something, but I can't believe it. And the other thing is, I wanted to see a gastroenterologist. I had a great gastroenterologist in New York. Well, would you know, in this area, I couldn't find one that does consultations. I thought that was really weird. Like, how do they know I'm gonna need a colonoscopy or whatever?
Yep.
I mean, so I ended up finding somebody in Hyannis who did see me, so it took several months. But I found that very strange. Why are they not seeing people first? What's going on there? They just don't get paid for it?
Well, certainly they would get paid for it. There's very few of them here. When we first moved here, there were 4 or 5 more than there are now. So I think that's part of the issue, again, is access.
And my third question, I'm sorry to take your time, but a friend of mine was diagnosed with cancer, and it was hell to get an appointment in Dana-Farber.
Yep.
So we had to go around and about to get it, and not all of us have that type of access. What does one do if one wanted to get, like, doing quality care for a particular disease? What do you have to do?
I mean, that's what the issue is. I mean, you have to be a squeaky wheel. I can, again, my victim over here, Marion has a problem called restless leg syndrome, and has been on medication, and it was getting much worse. So I did some research, and I found that all of the new guidelines were written at Mass General. And there's a lab, and they're considered the best anywhere for this problem. So we called to make an appointment, and they said the first available appointment was a little over a year away. So I read some of the research papers, got the name of the physician who runs the lab. And of course, you just can't call and talk to him. But I went into the research part of Mass General. I didn't know how to get in there. And his email was in there. So I emailed him, told him about her, told him who I was, and et cetera. And he got back to me right away. And he said, that's correct. No one can see her, for over a year. He said, but I have a small concierge practice outside of the hospital that I do virtually. I can see her for a 45-minute consult next week for, how much was it? $3,000 for that consult, for one visit, and that each follow-up visit, 15 minutes, was $800. And we had to pay by Venmo before the session was over. So this guy is a world-renowned researcher at Mass General. And so she has not seen anybody for this. I asked him finally, do you have names of anybody else? He said, he gave me 2 names, and he said, they're probably okay. And I said, what do you mean probably okay? He said, well, I train them. We called both of them. And the one that 6 months ago, they haven't called back. So, well, this is the problem with our healthcare system. And it's going to get worse.
And if he can't do it, I know you use your doctor credentials. Exactly. If he can't do it, anyway.
Yep. No, it's okay. Let me go through. Whoops. Whoop, I didn't want to do that. All right. So you have your appointment. You have your 15 minutes. You need to go in there and make sure that you get what you need in that 15 minutes. And one of the big problems is understanding what the physician is saying. They're in a rush, so they're going to use jargon because that's what they're most comfortable with. So always bring a list of questions with you. Focus on the things that are most important to you. Don't go off on tangents because nothing will happen in that visit time. If you don't understand something, ask. And if you can't ask the doctor, don't leave the office until someone explains to you what you need to know. And then ask about the best way to contact the doctor. It's usually via the portal. Now, the portal unto itself is an issue. It's a great device because you can communicate with your doctor, but when you have a lab test done, the results of that are for the doctor, but by law, you have to see it at the same time the doctor does. So you're going to get it, and half the time you won't have a clue. We have a friend who learned about a leukemia diagnosis from that. So you need, again, to be proactive about this. If you get something, you don't know what it means, don't panic. Try and find out what the information needs. And what I do, there are two things, is I always go to Medline Plus, which is the best government site for information. I also use ChatGPT, and I'll show you how I do that. And when you leave, I have a list of resources where you can get information for just about any medical condition. So very quickly, this is the homepage of Medline Plus. I had some lab work done, and on there I had a creatine kinase test, which I had never heard of. I had no idea what it was, ever. We never did it in kids, or it probably didn't exist when I was in practice. And I had no idea what it meant. Now, it was normal, but I had no idea what that meant. So what I did was I typed it into Medline Plus and got this. So I got a whole long 2-page list out in easy to read and easy to understand English. And it was a test for muscle problems because I had some muscle weakness. So. And the other thing is chat. That's the home page of chat. Has anybody used it? Yeah. Very easy to use. And for getting information, not for making decisions, getting information, it's very, very safe and very accurate. So I had some tests for a swallowing problem, and it came back as I had a prominent cricopharyngeus muscle. I'd never heard of it, ever. And I got an A in anatomy in medical school. No idea. So I typed it into chat, asking what it was, and I got this whole thing in simple language, so I understood what it was. And chat even proactively gave me a list of questions to ask my doctor, if I can see my doctor, about what this is and what needs to be done. This guide is incredible. There's a link to it on the back here. You can download it or read it online. And it's really about talking with your doctor and finding a doctor and all that kind of stuff. All right, quickly, health insurance. And I'm going to focus on Medicare because I'm guessing most of us are on Medicare, looking around. Do any of you have a Medicare Advantage plan? One. Nobody else. You're all on regular Medicare. Interesting. Good. Medicare Advantage, now more than half of Medicare around the country is on an Advantage plan. What it is the federal government, Medicare, contracts with a private health insurance company to provide you, if you apply for it, with Medicare benefits. They're given a certain amount of money for the number of Medicare recipients and how sick or how many visits those members have. Plus, they get them a little bit more. It's a big profit maker. So those companies are able to give you 0 to low premium, plus they can give you dental, they can give you eyeglasses, so there's a lot more benefits. The disadvantage is it's a restricted network. Under regular Medicare, you can go to any doctor anywhere in the country. With these plans, you are restricted to their network of doctors. And to get referrals, you need to see your primary care, and you have to pay, you have to get prior auth. So there's a lot of paperwork that needs to be done to get the services. And they tend to deny medications and procedures more often than regular Medicare. So let me tell you one story. Oh, whoop, I'm sorry. Keep doing this. That's correct. So the absolutely, and we'll get to the how much they make in a minute. So who should be on regular Medicare? If you want freedom to choose any provider, you see a lot of specialists, you have complex needs. If you spend time here and in Florida or travel a lot, the Advantage plans are difficult to coordinate from out of the state. And you can afford the supplemental Medicare plans, Medigap. And Medicare Advantage, if you're healthy, if you're on a budget and want no monthly payments, if you want extra benefits and you don't mind the paperwork and working in a network. I've always had regular Medicare. In 2021, I think I saw a doctor once. I had no problems, no ER visits, nothing. So, and my health insurance supplemental plan was going way up, as was my drug. So I said, well, gee, maybe I'll try an Advantage plan. So in 2022, I signed up for Tufts, has an Advantage plan. And 2 weeks into January, the shit hit the fan. And for the rest of the year, I had surgery. I was in the ER 4 times. I had COVID twice. It was the worst health year I've ever had. And it, I was constantly having to call my doctor's office to get a referral for things, which is a real bother. I had so many visits that the amount of copay I was paying by the end of the year went up to the amount I was actually saving. So it wouldn't have made financially any difference. The worst thing was, in 2016, I had cervical spine surgery. In 2022, my symptoms came back and I needed to have that surgery again. Originally, my surgery was done by the chief of neurosurgery at Mass General, who I loved. Well, guess what? Mass General was not in the network. And I called and I pushed and I, was a squeaky wheel. They were in the network. And it would have cost me probably $70,000 or $80,000 if I wanted to go there. So I wound up having it here. The surgery went okay, but it was not a really great experience compared to what I had up in Boston. So I'm back on regular Medicare, and I'm staying on regular Medicare. But again, if I had been healthy in 2022, it would have saved me $2,000 or $3,000. Oh yeah, we're going to get to that in a minute. So if you need help with a plan, which you probably do because it's complicated, statewide there are 110 different Advantage plans. There are 16 drug or Part D plans and 3 Medigap plans from 7 different companies. Good luck trying to pick one, if you want to change or you're new. So these are the 2 best places to go. Shine is a state agency, and during the open enrollment, you can go to the Falmouth Senior Center, sign up for it, and get all the help and advice you need, and they are terrific. The other thing you can do, Medicare of all the sites like this is the best. You can go on there, you can put in your zip code, put in your doctors, what drugs you're on, whether you want a regular or a Advantage plan, and they will show you all the plans that are here in this area, and they will help you pick and choose. And they really are right on target. So they're very, very good. You also can call them, talk to anyone, 24/7. And again, they're very, very helpful. Medicaid supplement. Medicare supplement, rather. You probably have one. Like a Blue Cross supplemental. Yeah, correct. You and you'll start seeing these in the fall. They're constant on television, trying to sell you an Advantage plan, plus all the stuff you get in the mail, and robocalls. This is all garbage, and they say things that border on illegal. They don't quite get there, but they imply that you get benefits that you don't get. So you got to be very careful with these. This guy is the anti-Joe Namath. He's a great physician, and he's got this sarcastic thing about health insurance companies, but I can't get it to play. So, okay, so we're towards the end here now. So this is an example of an evil empire. This is United Health Group. They're currently being investigated by the Department of Justice. This was the company whose CEO was shot and killed in New York, and his replacement was on the verge of being indicted for fraud and recently quit. So they are the largest health insurer in the country, especially when it comes to Advantage plans. They had two divisions, the insurance company, and then they have Optum Health Services, which owns doctors' practices, owns the PBM, Optum Rx, as well as a whole bunch of other things. So $22 billion in profits in 2023. And they are the most of any insurer in denying care. They deny, or have in the past, denied between 35 and 45% of all claims. And what happens is, if you're a squeaky wheel, it will get paid. But a lot of people give up and just don't pay it. They don't get paid, so they ignore it. So the company makes money. And they've also, in several places, they push lower cost treatments. So they won't deny the lower cost treatment, but they will deny something that's higher. Because they have a, yep. Yeah, this really is about money. And they, with their lobbying power, and the only thing that I think AARP does with them is Part D, which is the drug. I'm not sure if they do the whole, maybe they do, I'm not sure. But it's all about money. Okay, so there's a big conflict of interest. United Healthcare insures you. You then go to a healthcare practice like Atrius, which is owned by Optum, and you get your medication from their Part D plan. That is a tremendous conflict of interest. You're seeing a doctor who works for them, who can play around with your diagnoses in terms of what they report, so the company can make more money. And doctors have been quitting some of these practices because they're pushed to do that. And if they argue, they are fired. Read about a pediatrician this morning in Illinois who was fired because she complained to her boss in the practice that had recently been purchased by Optum. Again, it interferes with independent practice. We talked a little bit about that before. Lack of transparency. I mean, it's not clear what's going on half the time with them. And they exploit Medicare Advantage, and this is what they're being investigated now by Department of Justice, if we continue to have a Department of Justice. So taxpayers overpay because Medicare comes from taxpayer money, patients under-receive, and United Health profits. So this is a little haiku about United. United buys all, then cuts, delays, automates, care becomes profit. They count on you to give up, hang up, go without. That's the business plan. They own your doctor, your chart, your bill, your last breath, but they call it choice. Okay, very last thing. Does anybody know, we're playing a medical jargon trivia. Anyone know what this is? Can anyone pronounce it? Sphenopalatine ganglioneuralgia. Okay. It's very common here in Falmouth during tourist season. That's a hint. And it's not diarrhea. So. That's a further hint. Lots of people coming out of Dairy Queen will have this. Who? Marion, you know the answer. Anyway, it's the medical term for brain freeze when you eat ice cream. That's it.
My ongoing joke is that I'm suffering from androgen alopecia.
Here you go.
Male pattern baldness.
Aging. Okay, done. Any questions?
I just wanted to say, Mike, you are amazing.
Oh. Oh, thank you. And my next article in the Enterprise will be about the first part of this, the doctor thing.